At this time, I'd like to introduce our first speaker. So I am thrilled to invite Dr. Tabitha Thrasher to the conference this morning as our keynote speaker. She's an osteopathic family medicine physician whose alma mater is Rocky Vista University College of Osteopathic Medicine. Dr. Thrasher is a faculty member at the University of Wyoming Family Medicine Residency Program and the program director of the University of Wyoming Geriatric Fellowship. She is passionate about geriatric medicine and has a subspecialty board certification in geriatric medicine. She enjoys spending time with her family, being crafty, and also gardening, which again resonates with a lot of folks here. She was recommended to us as a speaker by our Wyoming colleagues at the Wyoming Center on Aging. So thank you to that team for bringing Dr. Thrasher this direction. Please help me welcome Dr. Thrasher this morning.
Well, good morning. Thank you so much for allowing me to come here and share some time with you all today. And for those on Zoom, hopefully I can make this as entertaining for everyone. I have to apologize, I'm a little nervous. So if I start getting the jitters or drop my stuff, just give me a little grace today. But Missoula, I've only been through here once before on my way to Spokane for an OB rotation and family medicine residency. I liked Missoula better than OB, but I love my colleagues that can do OB. It's not for me. I prefer the other end of life. So I just wanted to kind of start to tell you guys that when they asked me to speak here today, I was terrified, absolutely terrified. It took me about a week to answer and say yes, mostly because of my fear of public speaking. I'm better on the run with my residents. But when they told me what I was speaking of, that was the breaker. I was like, normal aging, normal, what is that? And so I was thinking, usually I'm asked to speak about dementia or heart failure, end of life care. And so this whole concept of normal just kind of froze me to the bone. So, you know, most of my days, of course, are full of guiding patients through things that have gone wrong. The advances of health and technology today have thus far been geared more toward the management of diseases to extend life. But it has yet to stop the deterioration of health. This means we are living longer, but not necessarily better. I hope things will be shifting more and more towards the guidance of patients more to prevent or delay diseases as long as possible. So I'm going to spend my time this morning speaking with you about aging and maybe getting you to rethink your retirement plans. I have no disclosures to disclose today. So for our focus today, I would like you to consider what is normal. What things impact the aging process in the body? What are some body systems that are affected with what I call usual aging? And have some key items to take back to discuss with your patients and how they can optimize their health. I'd like to start by asking, what is normal? The definition of normal is conforming to a standard, usual, typical, or expected state or condition. But how does that definition make sense for aging? Is my body doing it right? Is yours? Unfortunately, the idea of normal aging just doesn't make sense to me. I've seen 40-year-olds that are closer to their end of life than some 90-year-olds I care for. So I'd like to share a story, but don't judge me. I was right out of residency, my first job, so go easy. I had this patient. He was 40s, 50s, and he had a history of alcoholism, the sequela of ataxia, and he also had uncontrolled diabetes. So during my encounter with this gentleman, I'm asking him all the questions for diabetes, and I asked him how many sodas he drank a day. He said about 18. And I just kind of paused and I felt really bad because I stared at him horrified. Oh, and he said, what? I mean, didn't think that was that much. So we kind of continued on our journey together and questioning him. And he disclosed that he had about a 6-pack of beer a day. And as I shook my head, just in shock, one, because I don't know how anyone can get that much in their body in one day, but also just that a diabetic drinking so much soda, and then a patient having alcoholism and having a 6-pack of beer. On top of that, to me at that time was quite shocking. And he looked at me and he's like, but wait, that's so much better than I used to do. And of course, I congratulated him on his success. And later, I just happened to make a comment that I see many patients that are much older than he was, but he seemed to be my oldest patient. I know what you're thinking. How can you say that to a patient? But it was after a really long conversation with this gentleman, and I couldn't convey how concerned I was about his health at that moment, and I just don't think he was understanding it. Well, he remembered our conversation and reminded me of it at a later encounter. I know, he didn't leave me instantly, he came back, it's so shocking. But at the time he was feeling really poorly, and he mentioned he hadn't realized that his health was so bad before he met me. So we continued to work towards this goal of getting his diabetes under control and working towards cessation of alcohol, as it really was affecting his memory more and more. Unfortunately, he passed away not too long after that time of an acute illness. I often think of him when caring for other patients, attempting to meet them where they are and educating them in a positive manner, more so than a criticism, and attempting to educate them more fully on how to successfully age, which happens to be a fine goal, but I'm not sure I agree with the definition of successful aging. So successful aging can be defined as the absence of disease and disability, high cognitive and physical functioning, and active engagement with life. I can get behind some of that, right? The domains are very important. I like that part. But without disease and disability, without it, who came up with that? What about my individuals with hypertension? Have they failed at aging? Just failed, they're done. Well, I think it would be disheartening to those with genetic predispositions for something like high cholesterol, or maybe perhaps a congenital disability, that they have failed at successful aging. Shouldn't any age be celebrated as a success? I mean, think of the alternative. So my favorite part of the day is when I wake up. I pat myself on the back and I say, I made it to another day. I'm a morning person, it's phenomenal. I celebrate every morning. But it could be just me. So let's dig a little deeper into this idea of successful aging. There was a recent systematic review of about 22 studies that examined how older adults define successful aging. Relationships, being healthy, staying active and independent, maintaining cognition, adapting to physical changes, being supported, and having a good death were the most important things to older adults. This is what matters to them. Nowhere on this list is it being free of disease or disability. Rather, adaptation and support matter. Inherently, aging places us all at risk for gathering diagnoses. But what older adults are saying is, yeah, so what? I'm going to do my best to prevent or delay disease and help me if something happens. That's what they want. I certainly don't give my patients a pass to not try after they get a new diagnosis. We just shift our focus to how to prevent progression. I think it is important to think about the body and the changes that occur within it as we age to better define how we best guide our patients to prevent or delay the progression of diseases. I don't think my title is showing up, but it's supposed to be Foundations of Aging. To do this, we should first look at the foundation of aging and how it can be altered, affecting the changes that occur in the body and when they occur. Oh, fancy. Sorry about that. These things are known as the determinants of health. Trauma, genetics, lifestyle choices, and even our environment impact the body's aging. Remember, even when the fetus is in the womb, it can be impacted by things like alcohol, illegal substances, physical trauma to the mother during pregnancy, affecting the body enough to place them at risk for complications later in life that could decrease longevity. Through medical school and family medicine residency, I was introduced to the concept of adverse childhood experiences. I'm sure many of you are familiar with these as well, but as a refresher, since we're at a geriatric conference, I will go over these and why they're important to consider while discussing aging. The CDC and Kaiser Adverse Childhood Experiences Study is an ongoing longitudinal study of over 17,000 individuals. They're all aged 19 or older now, and they're kind of lumped in this groups of decades, so 20 to 29, 30 to 39, and so on. And about half and half, male, female, race, ethnicity, and education were also delineated in this study. So the goal of this whole study is to look at the relationship of these childhood abuse and household dysfunctions to many of the leading causes of deaths in adults. So they've divulged information regarding childhood experiences of their own, physical, emotional, and sexual abuse, neglect, household challenges like divorced parents, incarcerated parents, substance abuse or domestic violence in the house, or a parent or family member in the house with a mental illness. Added to these are discrimination, poverty, racism, and other violences enacted upon themselves or witnessing it, separation, and intergenerational and cultural trauma, which has been passed on. Also, adjusting to a major life change, perhaps losing a loved one, and working through grief and bereavement, maybe having survivor guilt, or those children that have had to take on the responsibilities of adults at a young age. There are just so many things that can impact a child and have a lasting effect. I can't even imagine the data we are going to get from children now that have lived through this pandemic. Be quite interesting to read about. They're very tragic, I'm sure. The loss of parents, grandparents, and others without the ability to gather for support. What coping mechanisms have they fostered to cope with the fears and stressors that came about during these past 2 years? How will this impact their health and life expectancy? As this study is ongoing, the data is not available yet, but correlations between these adverse childhood experiences and lifestyle choices due to these impacts are impacting how we age. And it's additive. The more ACEs someone has, the higher likelihood they will have more diseases. They'll have disability, possibly, and also decreased longevity. Consider a 60-year-old that grew up under the poverty line and had a parent that was an alcoholic. As an adolescent, they started working to help support the family, so they dropped out of high school. They lacked opportunities for higher education due to this, maybe married young to get out of the house. They spent a lot of time working to make ends meet for their family, now 4 kids. Both parents are working outside the house, so it's challenging to find time to cook. So there's a lot of fast food and maybe some hungry days. They were diagnosed with hypertension, diabetes type 2, and obesity in their 40s. For the past 15 years, they've had to decide whether to pay bills or get their medications. So they haven't been consistent with treatment plans and missed appointments with their primary care provider due to working long hours, and therefore have been shifted from clinic to clinic after being dismissed for no-shows. You're seeing them in clinic today. They're sweaty, short of breath, and feel like there's a band around their chest. Okay, no need to panic, right? This is completely made up, but I can guarantee that I've seen patients similar to this. Maybe not quite to the extent I'm sending them to the emergency department, or maybe some that I have. So I found this diagram to be very helpful. It outlines how the ACEs and inequalities disrupt neurodevelopment, causing social, emotional, and cognitive impairments that lead to poor coping strategies, causing social, emotional, sorry, when I get nervous, I tend to forget what I'm going to say, so I'm just reading a bit, so I apologize. Thus comes diseases and disability and an early death. So we are starting to see why normal aging is so hard to define, since we are all individuals making our own decisions which impact us differently, and why successful aging, defined as a lack of disease or disability, is hard to achieve and somewhat depressing to think about. Instead, I think I will call the changes that occur in the body the usual aging. I will be going over some of the systems in the body that appear to be affected by time. Even though when these occur, an impact they have on each of us could look completely different. Please keep in mind that I'm not detailing every change in the body, but rather attempting to target some of the systems that are most affected and place us most at risk for comorbidities. I'm also going to go through some of the ways we can identify impediments in our patients that place them at risk for decreased longevity. A team approach by provider, physical therapist, occupational therapist, speech therapist, pharmacist, social worker, and others is a great way to gather information and collaborate for treatment plans aligned with healthcare goals. However, this can be performed by a single provider over multiple visits when a team of providers can't be achieved. This has been deemed the rolling geriatric assessment. As we attempted to protect a vulnerable population from contacting COVID, we broke down the very pillars we found that help in an age-friendly healthcare system, a team-based care. I truly hope we can get back to this soon. I've used the 4 M's of geriatrics to help key in on these main systems. The 4 M's are the framework for providers to engage in age-friendly care, and therefore help us to tune in to the really important aspects of older adults' health as to make the best impact with our care. This framework was created in 2017 by the John A. Hartford Foundation, the Institute of Healthcare Improvement, in partnership with the American Hospital Association and the Catholic Health Association of the United States. This is a fabulous resource, absolutely fabulous. And the Institute of Healthcare Improvement website has a lot of resources to help us better to provide age-friendly care for our patients. I really encourage you to look more into this. It's available on their website. Initially, I'll focus on mobility and mentation, and the other 2 are really super important, so I'll kind of tie them in a bit later. Keep in mind that there has been a 5th M added to these original 4, and that's multimorbidity. It's placed in this talk is to know about it and the good management of chronic conditions to enhance overall health. So mobility, very key to continued function and independence. There are a lot of things that can cause decreased mobility, but I am looking at the usual aging on the body. You may very well have different opinions on what affects mobility, and I would probably agree with you. But for time's sake, I'll try to focus on a few key systems. The first is the musculoskeletal system. One of the most significant age-related changes that occurs in the skeletal system is the gradual loss of calcium from bone. If left unchecked, this can become osteopenia and then evolve into osteoporosis, placing patients at risk for fractures, unremitting pain, and/or immobility. There are changes that occur in the cartilage of stressed joints. It's rougher, inflexible, and wears away, allowing bone to rub together, causing pain and restriction of the joint movement. Over time, we may notice getting shorter as our discs in the vertebrae lose fluid. Our backs become stiffer, which restricts flexibility and can cause pain. Fluid loss in our tendons, ligaments, and loss of muscle mass decreases our strength and could lead to even sarcopenia, which is an involuntary loss of skeletal muscle mass and strength. Proprioception also changes, causing unsteadiness. These changes could lead to many disorders, including osteoporosis, as I said, arthritis, muscle cramps, and even falls. According to data from the CDC, every year, roughly 36 million older adults fall, and close to 32,000 deaths occur from these reported falls. 95% of the 300,000 hip fractures in older adults reported annually are from falls. So the very changes that occur in our body, the weakening of muscles, bones, and unsteadiness, and the disorders due to them, place older adults at high risk for morbidity and mortality. A mentor of mine often told me that her patients died from the sequelae of falls more than any other one disease. This table delineates differences in male versus female, age, race, ethnicity for fall risk. I had a patient tell me once after she had fallen and ended up with a vertebral compression fracture that it literally stopped her life as it was. She had pain whenever she moved, and she was scared to fall again. So she was more sedentary after that point. She stopped going out much and was isolated and lonely. This led to more significant depression. Falls can truly be life altering. But remember, falls are not part of normal aging. So what are some ways that we can screen our patients for falls? A good question to ask is, have you fallen in the past year? You may want to ask if they have any issues performing their activities of daily living or the instrumental activities of daily living. If they are having issues with toileting, transferring, getting up out of a chair, these are red flags for functional decline. It is also important to do a thorough foot exam. Feet can tell us a lot about the functional status of a patient. I can't count the number of times that I've taken off shoes in a very well-kept, well-dressed person, and there was nails that hypertrophic, dirty, corns, and you can tell they can't reach their feet. And so that can really tell you a lot about the patient's functional status at home. Corns, bunions, and neuropathy can all increase fall risk because of gait changes associated with these. A timed get up and go test is a good quick test to perform in the office. You mark off a distance about 10 feet away from a chair, have the patient sit down, advise them to rise from the chair, walk to the line, turn around, come back, and sit back down in their chair. All the while, your timing. A higher risk of fall is associated with those that take longer to get there than 12 seconds. Those at high risk for falls should be further evaluated with vision screening, balance testing, medication review, and it would probably be a good idea for a home visit to see if there are any environmental hazards like throw rugs, broken stairs, clutter that could be moved or fixed to decrease their fall risk. I hear quite often the answer to my "how did you fall" question to "my dog got under my feet." I rarely get anyone to agree to get rid of Fluffy, but it is definitely a consideration when you're working with someone with fall risk. They're wonderful for companionship, but they can get under the feet and cause falls. So we'll shift gears for a moment to our cardio and pulmonary systems. When discussing mobility, it is important to consider the heart and lungs, as these two systems impact mobility due to the usual changes that occur that cause more fatigue, decreased stamina, and therefore causing increased recovery time after activity. There are many changes that occur in the heart: thickening of cardiac muscles, decreased contractility, calcification of the arteries, and decreased pacemaker cells, causing more arrhythmias. Globally, our reserve capacity decreases. Heart disease continues to remain the #1 cause of death in the United States, followed by cancer and COVID now in 2020 data. There are many cardiovascular disorders associated with age: hypertension, coronary artery disease, valvular disease, and congestive heart failure, to name a few. It is not uncommon to have patients with many of these disorders weakening their heart. It is important to evaluate patients for edema in the lower extremities, exertional dyspnea, and shortness of breath. I tend to like to watch people walk out of the exam room or walk into my exam room. I'm sitting at the desk spying on my patients as they walk by. It's quite telling if they need to stop and take a break because our hallways are kind of long, or if they're wheeled in a wheelchair, which I don't usually use. It's very telling for that. I also tend to ask how they sleep. Are they in a chair? Are they propped up on multiple pillows just to breathe? These could be signs that there is a cardiac concern that needs further evaluation. Keep in mind, it could be difficult to distinguish between cardiac and pulmonary systems. I help our inpatient service with the residents, and quite often we're arguing or disagreeing between congestive heart failure or COPD. There's many times that it's hard to kind of delineate which came first and causes the other one exacerbation, or maybe there's not an exacerbation in one, but they're just sick with the other. So aging affects the lung by altering the alveolar structure, causing decreased carbon dioxide and oxygen exchange. There's also shrinking of the size of the lungs, increased mucus production, and a decreased cough reflex. So remember our aspiration. So these changes cause individuals to be more at risk for disorders like chronic obstructive pulmonary disease, pneumonias, and even lung cancer. In 2020, the data given to us by the CDC said that 12.5%, or roughly 30 million US adults were smokers. God, it's not billions. Cigarette smoking remains the leading cause of preventable diseases. With as much data that we have on the detrimental effects of smoking, I was actually very surprised that the numbers were still so high. So it's very important to screen your patients for smoking and work with them towards cessation. The usual changes in these three systems, the cardiac, pulmonary, musculoskeletal, really impact aging. However, we'll talk in a bit about how to delay these changes. Let's move our focus to mentation. For me, this gets personal due to family members that have had dementia, and because I work with many patients with dementia and their caregivers. According to the CDC, there are 6.2 million individuals in the US over 65 that are living with Alzheimer's disease. Many of my patients fear memory loss more than any other disorder. So I think it's important to understand the changes that occur in the brain causing increased risk for cognitive impairment. Dementia is not a part of usual aging. Some forgetfulness may occur in the aging brain, but not all forgetfulness is dementia. Keep in mind that many other things like genetics, exposures, and disuse impact the mind, placing some individuals at higher risk for cognitive impairment. Also, be wary of a depressed patient, as cognitive decline in them can mimic dementia. It is hard to truly diagnose cognitive impairment when a patient is so depressed that they can't focus or think clearly. I have a patient that came to me due to some memory concerns. They were unable to remember their grandchildren's name anymore. They're also having significant word finding problems. They weren't able to perform math, and she was a bookkeeper, so it was very difficult for her to not be able to perform math. She also relayed that she was severely depressed and had been most of her life, and that she would think daily that her family and the world would be better off without her. She'd even had a suicide attempt in the past. Many different antidepressants, psychiatry, counseling had been tried over the years, but she could not shake this feeling of not being worth it. I did a memory screen on this patient, and through it all, there was negative talk, anxiety, easy frustration that was displayed from this patient. However, they actually answered pretty well, maybe mild cognitive impairment. Once they focused, they could answer the questions correctly. She was also sent to neuropsychiatry testing because of these significant changes in her memory. And they also found mild cognitive impairment in a patient who could not remember her grandchildren's names. So I'm still working with this patient. Unfortunately, I have to say today we have not succeeded in getting her depression under control. I don't know whether this will continue to affect her memory and she will decline into dementia, or whether we will be able to help her at this stage in getting her depression better. So what occurs in the brain, increasing our risk for cognitive decline and other neurologic disorders? Unlike many other systems in the body, the nervous system does not automatically regenerate nerve cells that die. There is a loss of or shrinking of neurons as we age, and the brain decreases in weight and size. Many neurons have increased dendrite growth into very old age, which compensates for neuron loss in some areas of the brain. As nerve cells decline, there is a reduced strength of the message being transmitted, and coherence of the message is disrupted due to the increased space it has to travel. There is increased incidence of neuritic plaques and neurofibrillary tingles. Interestingly, the motor part of the older cerebral cortex may continue to respond even after stimulation ceases, which blurs the next message and could be why poor retention and distraction to learning and memory tasks. Sleep is disrupted also, with stages 1 and 2 increasing, and stages 3, which is deep sleep, and REM, rapid eye movement, decreases as we age. Speculation for causes of disrupted sleep patterns are decreased physical activity, daytime napping, drinking stimulating fluids, like all the coffee I had this morning, or just too much fluid near bedtime, eating large meals near bedtime, anxiety, stress, and of course, medications. Besides dementia, the aged brain is also at risk for Parkinson's disease, sleep disorders, and cerebrovascular accidents. We all know it's important to screen for memory decline. And one way to do this is a mini cog exam. You tell the patient 3 words, ask them to remember them, have them draw a clock with a time on it, and then ask them to recall the 3 words. If this is positive, I usually follow up with another memory screening aid, such as the SLUMS or the St. Louis University Mental Status Exam. There are other cognitive screens. I use the MoCA quite a bit in the past. However, it's become, you're supposed to pay for the MoCA nowadays, as well as the MMSE. So I don't use that one much anymore. It's also important to evaluate for reversible items affecting the memory, including sleep and depression. Watch the hands closely, especially if they reach for an item or while they're drawing or writing, to see if there's a tremor. Finally, I try to keep one eye on my patient and one eye on the individual with them, a family member or a friend. I've learned a lot from doing this. Mr. D, is there any concerns about your memory? No, there's no concerns about memory. However, his wife's going this in the background. That tells me it's a pretty sensitive topic and that I should tread carefully and not just bluntly bring that up, but rather I like to do a lot of times, I screen all my patients for memory. And how about we do this quick little thing? It's going to ask some silly questions, but it's very important for your continued health. And so it's important to be prepared for the emotion that memory changes brings in this setting. Anger, fear, sadness are common when the memory is mentioned. I've had people walk out, I've had people yell. So it's a big deal. Our senses are how we interact with the world. I'll focus on sight, hearing, and balance, keeping in mind that all of our senses help us interpret incoming information, integrate it with the knowledge of our body state as we are in that moment, and act on it adaptively. This is known as the receptor nervous system effector system. As many parts of the eye thicken, become more rigid, and yellow with age, light enters our eye differently, causing a loss of visual acuity. The ability to accommodate and refract light is also affected, lessening clarity, which challenges the ability to adapt to our environment. Continuing along this theme of hardening and becoming less flexible, the ear is also affected by these changes, causing an overall hearing loss, usually in the higher frequencies first. So I hate to admit it, ladies, it's not just selective hearing loss most of the time. Changes to the ear can continue to the point of inability to understand speech or full hearing loss. I have to pause here because I think it's fascinating how our bodies are. Our tiny little ear not only allows us to hear, but it also houses our vestibular system, which is in charge of our orientation and our balance. The inner ear houses these receptors within the bony labyrinth close to the cochlea. Aging causes a loss of hair cells and a reduction of the peripheral neural fibers, causing walking difficulties, problems with standing on uneven surfaces, especially in the dark, and general postural unsteadiness. All of this increases fall risks. In similar fashion to our other slides, here are some of the age-relating disorders of our senses. Another concern is how these changes and disorders place older adults at risk for cognitive decline, depression, decreased function, and for loss of independence. A loss of sight limits the ability to drive, and leaving the house can become burdensome. Loss of hearing could increase embarrassment, having to ask our loved ones and friends to repeat themselves over and over. And some individuals begin to isolate themselves even when they are surrounded by others. Loss of taste and smell may cause decreased enjoyment of eating, so going out with others may not be a joy anymore. Loss of balance increases fear of falling, and staying at home becomes the safer option. Loss of touch sensation causes safety concerns for burns, dropping things, and yes, even falls again. Sensory loss interferes with our ability to gather information about our environment, essential to the high quality of life. As isolation increases, mentation is affected, whether by depression or cognitive decline. So I definitely look in a lot of ears. They have hearing aids in them. I ask them to remove one at a time and then look in their ears to see if I can help with any cerumen impactions. I am very open and quick to connect patients with audiology and optometry. I really like to watch my patients walk, as I said earlier. Perhaps they're leaning to the side or walking towards the right all the time. Maybe they took a couple of seconds to steady themselves after standing up from a chair. These are all signs that balance could be off, and the quicker we find these impediments, the quicker we can help them and get them resources they need. The next system relates to mentation differently. It is not the changes directly, but how society reacts to them that can be quite detrimental. Skin is the largest and most visible of our body systems. It is also the tattletale of time, showing wrinkles, thin graying hair, and thickened nails. Dry, thinning skin becomes less elastic, more sensitive, and heals slowly. Plus, it starts to grow things like seborrheic keratoses. The dermatologist I rotated with in residency was in his 70s and had the skin of a baby. He would call these growths the carbuncles of life, and then he would nudge his patient and chuckle and say, I don't know why we have to worry about that. And they would both laugh and have an inside joke. So I tell a lot of people that story to relieve their anxiety about these benign growths, but also remind them to keep bringing up these concerns about their skin, as I would like to examine them regularly and be sure they are not changing and continue to remain benign looking. Also, our fat distribution changes. Some areas become thinner and some areas settle in nicely, like the abdomen in men and thighs of women, even without a caloric intake increase. Besides this list of skin disorders, the visible signs of aging have long been implicated as an influence on one's self-concept, secondary to how others treat older adults, leading to psychosocial dysfunction. The World Health Organization defines ageism as stereotypes, prejudice, and discrimination towards other or oneself based on age. This can be felt at any age. However, the young and old are both at increased risk for this. I see signs of this every day in my practice, in healthcare, as well as in our community. A particular case that comes to mind is of an 89-year-old that had a bicycling accident, leaving him with a broken clavicle, broken ribs on both sides, a subdural hematoma, and many subarachnoid hemorrhages. It was deemed that no emergent surgeries were needed, so the plan was to get him to a rehab center as quick as possible when he was accepted. The trauma team managed this patient for about 5 days of his hospitalization when a supraventricular tachycardia quickly got them calling our inpatient service with our residents to help manage the patient. Luckily, the SVT resolved quickly and he did have a history of this. However, one of the resident physicians noticed that he seemed a bit confused and he wasn't sure what his baseline was. By the next day, this patient was completely delirious. He had no safety awareness. Chart notes were questioning at that time baseline cognition, mentioning prior cognitive impairment, though it wasn't in the chart before. I was even asked to go ahead and discharge him to a rehab, but due to the hospital-acquired delirium, I did not agree. So our trauma team signed off as they had very little left to add, and our team started the process of working up hospital-acquired delirium. An active 89-year-old that biked 12 to 21 miles a day, lived alone, took care of all of his activities of daily living, was active in our community, and had a significant other. It was deemed that he had dementia likely instead of delirium, just because of his age. This could have been detrimental. Hospital-acquired delirium is associated with poor outcomes. Another example I had is a patient in one of my skilled nursing facilities that I work at. She's lovely, she's 86, she does not have dementia. She wanted to get her hair dyed blue. It had been something that she had wanted for a very long time. Well, she was told by the facility that she needed to ask her family's permission to get blue hair. I was quite upset at this because she's an adult female living at a skilled nursing facility. This is her home. She could make up her own mind and she had the funds to do it. Luckily, she advocated for herself and she looks great with blue hair. She's leaving her room more, being more active and engaged than I've seen her in the last 2 years with COVID impacts. So the moral is we want to live as long as possible, but we don't want to be old. So ageism is actually prejudice against our own future. Keep it in mind.
Okay, now the good part, the optimization. So let's review. We've discounted normal when it comes to aging, agreed that successful aging, considering the alternative is all aging. We went over some of the changes in our body from usual aging and how we can identify some of the impediments placing individuals at higher risk for morbidity and mortality. Now we can discuss optimal aging and how we can guide our patients to optimize their health. So it's not changing. Oh, is this on? Sorry. Okay, so optimal aging is defined as the capacity to function across many domains: physical, functional, cognitive, emotional, social, and spiritual, to one's satisfaction and in spite of one's medical conditions. So this brings me back to what I believe is one of the most important parts of the 4M's framework: what matters most. This is in complete alignment with my osteopathic training. When body, mind, and spirit are all aligned, then what matters most for health goals can be achieved. We need to have open conversations with our patients to understand what brings them joy prior to being able to guide them in ways to optimize their health. Here are some questions that can be used to guide the conversation. What brings you joy? What are some goals that you'd like to achieve within the next 6 months? Sometimes I get an unachievable one, like live to 150. Other times it's just, I would really like to be present at my niece's wedding in a year. So understanding what matters to them will help us continue this conversation with treatment preferences. I might think the most important thing to manage is their uncontrolled diabetes. However, asking what they want to focus on to achieve their goals, it might be to manage their urinary incontinence so that they can go visit with friends and not be embarrassed. So if we are able to elicit what concerns and fears they have about their health, we have an opportunity to educate them and maybe get them connected with community resources for support. I tell my patients all the time that knowledge is power. The more they understand what is going on with them, the better prepared they will be to make decisions about treatment. They also tend to be more invested in their treatments. So our focus should be on helping patients achieve their goals and keep what they love. I reviewed a lot of articles, websites, listened to a few podcasts, and had conversations with a lot of my colleagues about the best advice for optimizing health. Exercise, nutrition, sleep, avoidance of disease-causing agents, practicing preventative medicine, and early treatment of diseases and medical conditions are the primary biological activities or factors shown to increase the chance of aging optimally. There are many lifestyle changes that help, including keep moving, get your nutrients from food, prioritize healthy coping strategies for managing stress, continue to learn, find your tribe, and see your health provider regularly. Just move. I like to be sure to go over the difference between being active and exercise. I remind my patients that exercise is a dedicated amount of time getting the heart rate elevated. So when the CDC recommends 150 minutes of moderate exercise per week, these activities need to raise the heart rate. Then they should be active for the rest of the day. Limit sedentary activities. Strength train 2 to 3 times a week for stronger bones and more flexible, resilient muscles. The more I learn about the detrimental impacts of being sedentary, that this impacts our body and mind, the more I am rethinking what retirement means. I'm starting to think less about resting and more about de-stressing. I don't know if that's a word, but I'm going to use it. So I want to find something I'm passionate about and continue to be active and engaged in life. Perhaps to me, this looks like living in Belize and leading active older adults on nature hikes for bird watching or animal spotting. There is a lot of research out there that prescriptions for exercise helps motivate patients to follow through with our recommendations. But what about my patients with heart disease or COPD, you might say? Well, in this article published in 2006 by Peterson and Sultan, a comprehensive review of evidence for exercise therapy as a treatment for different chronic diseases was performed. You can see all of the chronic diseases they reviewed, and they look at the the effect of exercise therapy on the disease pathogenesis, symptoms, physical fitness or strength, and on quality of life. They gave ratings of strong evidence, moderate evidence, limited evidence, or no evidence. It is no surprise that there was strong evidence that exercise has a positive impact on most of these chronic conditions. I would just say that in your patients with heart disease, starting slow or even exercising under surveillance, like with a trainer or through a cardiac rehab process, should be advised. Remember, after a myocardial infarction or heart attack, Exercising regularly and early, even within the same week of discharge, improves your outcomes. I read a quote by a geriatrician. Her name was Dr. Maria Fiataroni. I'm sorry, I probably butchered that. And I just love it. She said, rather than seeking permission to exercise, you should have to get permission to be sedentary. So I have to encourage movement with all my patients every day, all day, more exercise. Okay, so as I mentioned earlier, a lot of changes in our body cause us to be more at risk for falls as we age. However, we can do a lot to help our patients to prevent falls. The CDC has a lot of data on falls and has even implemented the Stopping Elderly Accidents, Deaths, and Injuries Initiative, or STEADY. We should all screen our patients over 65 for falls, and if positive, evaluate them further with the timed up and go test that I mentioned earlier that Sue might demonstrate in a bit, or even a 30-second chair stand. My patients hate this one. I make them sit and stand without using their hands multiple times to see if they can do this. This really tells you a lot about their core strength and their ability to maybe get up off the floor if they do fall. Then we need to educate them on ways to prevent falls, like getting rid of their throw rugs, exercise regularly, eating healthy, staying hydrated, and be sure to wear non-slip shoes or socks when walking around their home. Another key component is getting back to our sensory changes. Be sure they can see well. Are all of their chronic diseases optimally managed? I am well acquainted with many of our physical therapists, occupational therapists, and other therapy sites in Casper, Wyoming. Not only can they assist with our strength and endurance, but also with gait training and balance support. Stopping falls prolongs independence. Shifting a bit, I'd like to talk about nutrition, but before giving advice about nutrition, be sure to assess for malnutrition or unintentional weight loss. I look at weight trends a lot, especially in my skilled nursing facility patients. You can also perform a mini nutritional assessment. They may need further evaluation for weight loss if this is positive. A quick look in the mouth, question if dentures are worn. Ask about vision loss or tremors. There has been a lot of research on nutrition over the years, and the USDA even publishes a dietary guide for Americans every 5 years or so. The current one, I think, is between 2020 and 2025. It's about a 164-page booklet. It's huge. It's full of great data to get better educated ourselves and to share with our patients. Key things to think about with our patients is, how is their dentition? Are they able to eat, to taste or smell? Do they have difficulty swallowing? Are they able to use utensils? There are a lot of adaptive devices that can help with these issues. Remember, as we age, our loss of taste, except for sweet and salty, comes out. So many older patients might gravitate towards sugary foods or salty foods just for that sensation. An occupational therapist can assist with evaluating patients and recommending devices if needed. If you are lucky enough to have access to a nutritionist, they can be a great resource as well. Another thing to consider is the ability to prepare meals for themselves. And are they eating alone? Casper has a Meals on Wheels program. It's just great. It really does get people to eating a little bit more healthy than just something they can grab. So be sure to get what you need from food, and moderation is best. We should be eating to live and not living to eat. Encourage healthy meals with whole foods eaten with friends and family. A healthy diet is key to decreasing mortality, frailty, and loss of quality of life. Many chronic diseases like macular degeneration, stroke, heart attacks, osteoporosis can all be slowed by dietary interventions. How can we advise our patients to protect their brains? There's evidence that heart and brain are linked, and both are placed at risk for many of the same factors like smoking, obesity, dyslipidemia, hypertension, and atherosclerosis. So aiming to lose weight through diet and exercise, keeping regular medical appointments for the management of cardiovascular disease and smoking cessation helps both our heart and brain. Keep the brain active by participating in mentally, socially, and physically stimulating activities. Learn a new language, take a cooking class, do Tai Chi, learn how to use an electronic device. Remain socially engaged. Research is showing that diets high in fish, fruits, and vegetables, like the Mediterranean diet, can protect the brain and lower dementia risk. Finally, we get to our fourth M for our 4 M's, medication. I bet you're all wondering, thinking I forgot it, but I didn't. I told you this one was important. Not only is it important to frequently assess medication that patients are taking, but to be sure you put this into part of your plan for prevention as well. Are the meds causing dizziness, vision changes, fatigue, tremors, confusion? Have you guys looked at the Beers list? Every medication out there is pretty much on that list. So there's a lot of medications on this list that have side effects that cause morbidity and mortality in patients over 65. When trying to help someone, we can sometimes cause a lot of harm with our medications. However, there are times that medication is needed to optimize a chronic condition. There's an app on your phone or on the computer that you can get called the Start Stop app. A great resource to consider which meds are needed and which ones can be stopped or weaned off. Many of the medications we do need to start on this app are evidence-based for diseases like heart failure, COPD, and cardiac arrhythmias. Are they on a lot of anticholinergic medications? These medications have side effects of dry mouth, constipation, urinary retention, bowel obstructions, impaired memory, blurred vision, increased heart rate, and decreased sweating. You can calculate the anticholinergic burden of your patients, remembering that any score over 3 is associated with increased cognitive impairment and mortality. Do the medications make sense? Are they on Lasix and oxybutynin? There could also be a prescription cascade. I had swollen legs, so I was given some Lasix. I went back a couple months later because I couldn't stop peeing, so I was given oxybutynin. A month later, I was dizzy, so I was given meclizine. And perhaps had we maybe decreased or changed the Lasix to every other day or educated, they wouldn't be on 3 medications for one problem. Medications can cause issues with mentation and mobility. I tend to think of medications first when my patients come in with new concerns and ask about any new medications, any new supplements, any new herbals like teas, etc. I had a patient come into me once with blurry vision and stated she had been advised by her optometrist to come see her primary care because her eyes were fine. She also presented to the ER for the same issue earlier on, and a CT scan was normal. So the ER had recommended the vision evaluation. She went and got her vision screened. It was fine, so she came back to me. Onset was about 6 months ago. She denied any changes to medications and pretty much stated nothing had changed, but she got blurred vision. Finally, I asked about supplements, and at first she said, nope, I didn't start any supplements. But then she said, actually, you know what? I have started a new memory supplement. So I asked what the name was, and And I looked it up and it correlated with around the same time that she started with this blurred vision. And sure enough, one of the side effects of this memory aid was vision changes. So I asked her to trial off the supplement and her vision cleared. Think of her cost for an ER visit, a CT scan, and an acute optometry review, which all could have been stopped had we known about the supplement and the side effects of that supplement. So always review meds and supplements. I want to emphasize how important preventative care is for optimizing aging. Regular medical visits are essential for helping our patients achieve their health goals. When we work in collaboration with our patients, we can decrease the risk of chronic disorders by implementing preventative screenings for cancers, aneurysms, and even blood pressures, and educate them on lifestyle changes for better overall health. The Medicare annual wellness visit is one strategy to keep on top of preventative screenings patients have. Please remember that these annual Medicare visits that are paid for are usually hands-off by a provider. A lot of questions, I think there are like 70 to go through, and then they recommend a follow-up with the primary care provider for further evaluation of the pieces that are missed. So many patients come to me, want their free visit, but they also come to me with their acute visit stuff too, because they want to pack it into a free visit. And I can't touch a patient during that visit. I'm not allowed to. So just remember that when you're going into your Medicare wellness visits. So finally, it's never too late to change your health. I have a couple of inspirational examples to end our time today of people who I believe are doing it right. I don't have a picture of the first one, but it's a story of a patient of mine. She's in her 80s, and I met her when I was a resident. She came to me with breast changes about 8 months after a normal mammogram and ended up having invasive ductal carcinoma. This was about 8 years ago or so. When I moved back to Casper to teach at our residency program, she became my patient again. I unfortunately diagnosed her with her second cancer earlier this year. I bring her up because she inspires me. She continues to go to the gym and exercise, and even joined a project that our clinic had for a tele-exercise program through the University of Washington. Though this time her treatments have been more challenging, causing significant side effects like severe neuropathy in her hands and feet, she remains positive and continues to live every day as best she can. Her goal with this diagnosis was to make it to her niece's wedding. That's why I brought that up earlier. And she was able to be there. She has had to give up her love of crocheting and knitting because she can no longer hold her hooks. So I'm trying to work with her and see if there's any adaptive devices that might help her keep that passion. But she's a phenomenal patient. So I was told by my dentist that I should listen to a podcast interviewing James E. Owen. He's the author of Cowboy Ethics and Just Move, a new approach to fitness after 50. At 70 years of age, he decided to get into shape because he was having severe, debilitating back pain. He had never been an athlete and claimed to be a couch potato before this age. Within 4 years, his back pain had resolved with exercise, diet changes, and weight loss. I encourage you all to watch The Art of Aging Well, which is a 30-minute documentary he produced. It is very inspiring as it features older adults that have implemented lifestyle changes to better their health. It is James's passion to fill the inspiration gap on the subject of aging, and he has found his purpose in motivating and inspiring others to adapt healthy lifestyles. I'm sure some of you have heard of Julia Hurricane Hawkins. She ran the 100-meter dash at age 105 last year in just over a minute's time. I loved watching the clip of her running. Now, she did happen to be an athlete for most of her life. She never really slowed down, but she decided to compete in the 100-meter dash at age 100 after one of her children suggested she should. Her ability to hear the challenge and accept it at her advanced age is truly inspiring to me. Her advice is for people to keep running and be healthy. Interestingly, I went to the Senior Olympics in Casper, and there was about a 98-year-old that was running the 100-meter dash in boots because he'd never run in anything else, never walked in anything else. So he ran it in boots. He did wonderful. My final inspiration is Della Works. She is the mother of Dr. Cindy Works, my friend and geriatric mentor in Casper. And Della is a Casper icon. Everyone knows her. Everyone knows Della. She started running at the age of 49. Her son motivated her to run that year and later died in a plane crash. She says that running is a gift he left me because it makes me feel really good. She has been all over the world running. She's in her 80s now and still running. She ran at our parade day. There's a big parade that we do every summer, and she ran this year, and it took so long for her to finish. The parade was held up, but she was running down the street with the parade behind her playing music, and she was just going to town. Everyone was clapping. It was amazing. It was the best thing. So Cindy tells me that her mother taught her how to truly live. All of the resident physicians that go through our program spend a day with Della during their geriatric rotation. She inspires them with her active daily routine, and most of them say they can't keep up with her. So to recap, everyone is unique with a different aging journey, impacted by their own determinants of health. All organ systems are affected by aging, but I believe there are some like the musculoskeletal system, nervous system, and cardiopulmonary systems that place older adults at higher risk for age-related disorders, morbidity, and mortality. By using the 4Ms framework, we can collaboratively work with our patients to align treatment plans with what matters most to them. Be active, stay hydrated, eat a healthy diet, and find a passion are some of the practical points for your patients. Try to inspire all patients, no matter their age or affliction, to fight for their health so they can keep what they love. Thank you all for your time today. I have references on the next couple of slides, and I think there's some time for questions and answers.
Thank you very much. And all that inspiration. I don't think there's anything wrong with running in the 24th parade and having everyone clap.
She honestly thought they were cheering her on, which they were, but the parade was coming too. So everyone, it was just the best thing in the world.
So we have the ability to use the mic to have you ask questions. And then there's also the opportunity online. So Gretchen has just pushed a prompt through to everyone that's joining us on Della. And it's in the dialogue section, Gretchen, I believe. Dialogue? Yes. To ask their questions. So that's what I have pulled up here. Oh, if any questions come through. So how about questions for here in Missoula first?
I think this is inherent in what you said, but as an occupational therapist, I work in a dementia program through the Missoula Aging Services. The whole concept of adaptation, the ability to adapt and related to cognition and quality of life, I think is huge. So people who may have physical limitations, age-acquired things, traumatic, the adaptive, mental health, I work a lot in mental health. Those who can adapt function well and age well. those who can't adapt well, they don't, they mentally age way too early, I think.
Absolutely.
But I think it's built in, but I think the concept is a really important one.
Yeah, adaptation, support, all great things. Yeah, I agree.
And we have a speaker talking about adaptive technology today as well. Other questions or comments?
I missed your name because I was a little late, so sorry about that.
I'm Tabitha Thrasher.
Tabitha?
Thrasher. Yep.
Thrasher.
Trasher. I think I can go back to my first page, which has it on it.
For those of you in Billings, I would suspect you can unmute and ask questions
There we
as
go.
well.
Got off easy.
That's because you.
Oh, that's- I saw your slide on medications and pharmacy. And I wondered if you wanted to touch a little bit on e-prescribing and what success you had with that. The newer concept that meets with some resistance.
Let's give you the mic.
Well, I have no problem with the prescribing. It's been a bit challenging, but it's also been actually quite a blessing in some cases. Before, with a patient that needed an opiate for even hospice care, I would have to get to my clinic, print off a script and get it to them, to the pharmacy. So it took more time. Whereas now, wherever I'm at, I can get online with my two-step authentication and get a patient the medications that they might need in that moment. So it's been a bit of a blessing there. It is kind of challenging whenever you can't find a medication or it doesn't go through and you don't know it, and patients at a pharmacy waiting for it, and I don't know that they didn't get their script and it's somewhere out in La La Land or the cloud, whatever that is, eating up my prescriptions that don't go through.
Other question.
Oh, there we go.
I have a question.
Yes, go ahead.
Am I on?
Yes.
Oh, cool. Yes. Okay. You were talking about the Medicare wellness checkup and that being free, and how you're not able to touch a patient that comes in trying to cram other, acute illness or so I'm wondering, because I'm like, well, what if it's pretty, pretty dire or something, but you said you're not able to touch that. So I'm just wondering how often that happens, and yeah.
So, if there's something dire, I touch a patient, but unfortunately it's a different charge. So it just happens a lot of times. Maybe I'll see a patient once a year, but they want that to count as their Medicare wellness, which is covered. And it's a different setup. It's questions and talking about preventative care more so than my physical exam and diagnoses and changing medications. So it's just a different code. And so Medicare doesn't pay for the physical exam portion of a clinic visit through that annual wellness visit. Does that answer your question?
Yeah, I think so. I was just kind of I kind of went, what? Because
So
I
did
know
I.
there's always that insurance thing going on, the money thing, and I'm just, was wondering how often that happens, if that's a big deal, or, that's.
it's a big deal more to the patient that gets the bill later, because they think it's free. So it's, and I try to remind everyone, if they're coming in and they expect this to be that visit, that it's a different visit. And I kind of tell them what is on the visit plan for that, these questions that Medicare collects so they can better enhance, yes, their insurance program with data that they collect from patients.
So I'm kind of curious how you balance your time with your visits with patients on the counter, because this is obviously a lot.
Yeah. That's a great question. I think we'll all be interested to.
Oh, very well. I've had to change visits around a bit to allow more time. One, because I think important aspect of a clinic visit with my patients is that social engagement. So they want to ask about my daughter. Most of them know I have an 8-year-old, and then we have to get to what I think is important, and we have to get to what they think is important. So if I'm able to, I like to try to kind of lay out what I'd like to do. I think that I need to cover your diabetes today and do a foot exam. However, I want to leave some time so that we can be sure to cover what you think is important as well. I have to have people come back. There's no way I can get everything in. I think there was a study recently that went over how much time a primary care provider actually needs to do everything on the checkbox, and it's more than a day's worth of time. And so I don't really know, but they'll probably get me quoting a study that I don't know the answer to, but it's huge and very difficult. A lot of my patients, I end up calling on the phone, and unfortunately, I don't get paid for some of that. And so it's just out of the trying to be complete and work for their health that I do it, because I don't want to leave someone out there for another month before they can get into me with unanswered questions. So a lot of phone calls, a lot of discussions with family as well as the patients themselves.
Well, I'm not gonna tell you who my primary care provider is, although my last wellness visit, that person was kind enough to give me a breast exam. Very brief, and she said, Medicare doesn't want me to touch you, but she asks, and if people are receptive to that, she'll do that, and I'm very appreciative.
That's a good point.
I honestly think more often than not, patients give up their free visit to discuss what's really important to them. So to have me do the exam to discuss further how I can help with their health. That's why in Oregon, we had a completely different set of people doing the Medicare wellness. It was an LPN, and she was lovely. She got all the information. She'd give me a heads up and schedule an appointment for me to meet with my patients so we could talk about their health.
Thank you for all of your comments. I'm curious, are you in practice by yourself, like a physician-owned clinic, or you work as part of a larger entity?
I work for the University of Wyoming Family Medicine Residency Program. So my time is split between clinic and working with patients, or excuse me, with residents in the hospital setting. I cover one of our nursing homes in town. We do inpatient. I sit in the attending room a lot so the residents can come talk to me as they're learning how to care for patients better. So I only have a clinic about 2 half-days a week, and then 1 half-day of nursing home care. So the calls come in a lot. I'm doing a lot of management on a nursing home over the phone. So a lot of time.
We do have one question by Vetla. Sure. If you want to read it.
Have you or other providers you know had experience in using the SAGE, which is self-assessment of gerocognitive evaluation with individuals? If so, have you found any differences in how the individuals perceive, accept the assessment in their home versus one of the other administered in the clinical visit? No, I unfortunately haven't heard of that. So it would be very interesting. I'll have to look that up. If anyone have any experience with that here?
What's that question?
It's asking about the SAGE, the self-assessment of cognitive evaluation.